Welcome back to August 1st, Substance Use Disorder 3D Echo. We're thrilled that all of you can make it. We know it is prime vacation time. So for those of us who aren't on a beach right now or are making it in spite of being on a beach, we're really grateful to have you with us. If we could do a quick round of introductions for the hub, and then we'll get started. I'm Bob Seiss, addiction psychiatrist.
Amber Rogers with Mountain Pacific Quality Health.
Mary Argonis from Mountain Pacific.
And Jessica Fry from Mountain Pacific.
Excellent. And Malcolm will be joining us about 20 minutes late. That's Dr. Malcolm Horn from Rimrock Foundation. Let's go ahead and get started. If we could ask everyone else who's attending, if you would please type in your name and the organization you are representing in the chat box. We'd really appreciate it. And could I get confirmation from Amber, Mary, Jessica, someone that you're seeing the initial slides of the presentation? We good?
It needs to be smaller.
Needs to be smaller. Okay, let's fix that. Is it still too big?
Perfect.
Perfect.
Excellent. Thank you so much. Great. So we are offering continuing education, both medical as well as nursing. You get 1 credit hour by attending this, and please sign in using the link that Amber will provide in the chat box. Brief disclosure, I, as well as doctors Eric Arzubi and Reza Hosseini Gomi, are co-founders and co-owners of Frontier Psychiatry. Reza, as well as Amber, have the commercial interests noted here. The nurse planner will ensure that the program remains free of bias. Announcements. Amber, please take it away. Do we have any announcements for today?
The only announcement that I have is just in terms of the credits, I will be sending those out after the series ends, and we'll have attendance about how many you attended. So if you're not keeping track of it yourself, I'm keeping track and we'll send that out to you so you don't have to work too hard at it.
Wonderful. We so appreciate it. Let's start off with a case discussion. This is Mr. HG. He's a 37-year-old man who presents to your clinic. He's currently unemployed and homeless. Past psychiatric history is remarkable for long-standing depressive symptoms. No prior history of psychotic symptoms until recently. He tells you he oftentimes feels extreme anxiety and has thoughts that scare him. He thinks that a group of people are stalking him, and he says, I don't know who they really are, but I'm starting to see them everywhere. He's using over 1 gram of methamphetamine daily, remarking, quote, I thought I had it under control. Recently, I started injecting. Now I just can't stop. He's currently off psychotropics, knowing that only methamphetamine really touches him. He notes about having some potential interest in cutting back, if not stopping his meth use, but voices ambivalence, remarking, it's awesome. It makes the sex great, but I just got out of the hospital. I ended up there because of bad burns on my skin. I'm not sure how I got them. Maybe I messed up putting bleach on my athlete's foot. What can we do to treat this patient? And these options are not mutually exclusive. Insist on abstinence from meth prior to prescribing any sort of medication. Tolerate meth use so long as he's only using less than 1 gram daily. Prescribe bupropion and intramuscular naltrexone as medication-assisted treatment for meth use disorder. Engage in motivational interviewing, targeting meth use reduction and or cessation. Proceed to treat psychosis and anxiety with evidence-based pharmacological treatments, and or provide contingency management. Of course, I flash forward and I'm giving away today what I think the evidence and really current practice if you talk to folks who specialize in treating meth use disorder favors. We'll talk about medication-assisted treatment and how, in particular, bupropion combined with IM naltrexone may be all we currently have for the broad population. With some caveats, we'll discuss that in detail. Motivational interviewing tends to be one of the most accessible ways to talk to people about their substance use, although perhaps when it comes to methamphetamine, the evidence insofar as motivational interviewing making a big difference may be less in comparison to treating alcohol use disorder. In general, treating everything co-occurring with substance use disorders is what the evidence favors overwhelmingly. And we see this a lot in practice. Contingency management, along with CBT and a couple of other psychosocial interventions, have the greatest evidence for making a difference in helping people cut back and ideally abstain from meth. Really, it goes well beyond the medication-assisted treatment and efficacy. Our objectives today, we want to acknowledge how methamphetamine works, discuss the effects of methamphetamine, acknowledge the history and epidemiology of methamphetamine use, and talk about current forms of treatment for methamphetamine use disorder. Methamphetamine. We need to emphasize the difference between methamphetamine versus amphetamine. Both impact the levels of catecholamine, specifically dopamine, as well as norepinephrine. And to a lesser extent, another neurotransmitter, serotonin, increasing the levels of these neurotransmitters in the synaptic clefts. The big difference in bold is that methamphetamine increases the dopamine level remarkably more in synaptic clefts, way more than amphetamines. And not to go too deep into the weeds, but to look into the mechanism of action, this is by increasing the release of these neurotransmitters, principally dopamine, and blocking the reuptake. So you see increased dopamine production, increased availability of dopamine and norepinephrine in the cell, and then a reversal of transport of these neurotransmitters along with serotonin through plasma membrane transporters, blocked activity and expression of transporters, especially for dopamine. So they're not seeing, the synaptic clefts are seeing less transport of these neurotransmitters out from the synaptic cleft back into the cell. So if they're hanging out more, they're in the clefts. And you also see inhibited enzymatic breakdown of neurotransmitters in the clefts. The net result is a lot of dopamine, an explosive amount depicted here in this diagram. And this encapsulates everything we discussed on the prior slide insofar as the mechanism of action. Here we're seeing the ventral striatum, which is a core part of the dopamine circuit, expanded out. How do people consume meth? About 2/3 of use is in the form of smoking, about 1/3 snort, about 7% inject. And injection methamphetamine use is especially concerning because people see the positive effects and the reinforcement way faster and the potency is higher. And then a very, very small minority, about 3%, ingest methamphetamine. The clinical effects of use are almost immediate, again, acknowledging that the route of administration does influence how quickly. If we think about acute use, a lot of what we're seeing is what you'd expect to see with amphetamine use, and then a whole lot more. So a lot of energy and alertness, decreased need for sleep, euphoria and other mood changes, including irritability, anxiety, aggression, and/or panic, increased sexuality, excessive talking, tightened jaw muscles, and teeth grinding, dry mouth, loss of appetite, disorganized thinking, itching, and an overall hyperactivation of the sympathetic nervous system. Get diaphoresis, mydriasis with dilated pupils, increased heart rate, and other cardiovascular changes. What happens long-term with chronic use, especially if people are using methamphetamine virtually every day for several months? The long-term effects are essentially everything we just reviewed carried out over time. So you get a sleep disruption and outright insomnia. You can have mood changes to the point that there's apparent mania or a mixed mood episode, high-risk sexual behaviors, and an association of increased risk of sexually transmitted illness, tooth decay, damaged dentition, in part due to teeth grinding, but also dry mouth can cause teeth rot, psychosis resulting from disorganized thinking, meth sores from skin picking, combination of the itching and psychosis is perfect setup for that. And insofar as the impact on the cardiovascular system, you can see malignant hypertension, arrhythmias, even aortic dissection, myocardial infarction, stroke, cardiomyopathy, overall increased mortality. Insofar as the effects we see fairly often, psychosis is documented to occur in around 40% of people who regularly use methamphetamine. Super significant for those of us who work in emergency departments caring for psychiatric patients. Increasingly, this is accounting for at least a third, if not in some cases, a majority of patients we end up seeing in the ED. The long-term cognitive deficits associated with chronic methamphetamine use are significant. In an American Psychiatric Association study, they saw a medium effect size insofar as the deficits associated with chronic meth use, in particular, episodic memory, executive function, information processing speed, motor skills, language, and physioconstructual abilities all took a hit. I think as someone who studied history and kind of thinking about what a substance means to us as a people, the significance of it, and the epidemiology, I think looking at the history does help us understand perhaps a direction our country can take insofar as the methamphetamine epidemic. So meth has been around for a really long time. It's first synthesized from ephedrine in 1893 by a Japanese chemist, Nagai Nagayoshi. And then starting in the 1930s, 1938, a German pharmaceutical company began mass marketing Pervitin, which was over-the-counter methamphetamine. It was consumed by the civilian population, especially people who had to work long shifts, and it played a very central role in World War II. The Wehrmacht used it across all lines of the armed forces. In particular, there is significant evidence it was used in the Blitzkrieg. And it would make sense that if you wanted a drug that would give soldiers the ability and tank drivers to go 3 to 4 days without sleeping, methamphetamine would serve that purpose. It's worth noting that as the war continued, they saw more and more deleterious effects from long-term methamphetamine use, including agitation, rage, and in some case, soldiers not only acting out in combat against the perceived enemy, but also acting out against superior officers. Current epidemiology of use. This is kind of a heat map of the world. Granted, this is all-comer psychostimulant abuse. Meth is only part of it, but it does generally track. And we see that in the United States in particular, we're at about a 3% incidence rate. And the regional trends, this is the rates in the older adolescent adult population per 100,000. We see here in the West, we've stayed consistently high at, now approaching, about 180 per 100,000. It's the rest of the country that's catching up. And sure enough, if you track over the last 10 years, here in the West, we're higher too. But you've noticed, especially in the national conferences on treatment of substance use disorders, places like the South and the Midwest are talking about it a lot more because they're seeing it more often. So it's gaining a lot more national attention. When it comes to medication-assisted treatment, there's poor evidence for the use of psychostimulants. Here we're talking about, for example, amphetamines, and using them as some sort of agonist therapy. The logic here is something analogous to using something like Suboxone or methadone in the case of opioid use disorder, using a mu-opioid receptor agonist to essentially supplement for the substance of abuse. A Cochrane review from 2013, a study from Dr. Chan and co-authors in 2019, revealed there's really weak evidence for using psychostimulants to treat methamphetamine abuse. Mirtazapine, the antidepressant, has shown some benefits in improving retention and treatment and decreasing the number of methamphetamine positive urine drug screens in cohorts of patients from 2 studies in particular, Colfax and co-authors in 2011, then Coffin and co-authors in 2020. It's worth emphasizing both of these studies were limited to men who have sex with men. So this has not been replicated in the general population, but it's something we think about when perhaps treating patients from this population. In the most recent study on medication-assisted treatment for methamphetamine use disorder, published in January of this year, Trivedi and co-authors looked at the use of oral bupropion and intramuscular naltrexone to treat methamphetamine abuse. So there were some earlier studies using oral naltrexone plus oral bupropion. Initially, it looked kind of promising, and then they really failed to replicate the results in larger follow-on studies. The logic here is that naltrexone does have some evidence for reducing the reinforcing effects of amphetamine, in particular the cravings, and could potentially decrease the likelihood of relapse. Bupropion, in turn, reduces Q craving and may decrease methamphetamine use over time. So take individually good things insofar as helping with methamphetamine use, combine them, it should help, right? So they included over 400 participants in a multi-site, double-blinded, 2-stage placebo-controlled trial. The intervention consisted of intramuscular naltrexone, brand name Vivitrol. This is 380 milligrams injected gluteally every 3 weeks, combined with essentially max dose extended release oral bupropion. And they chose adults who had moderate or severe methamphetamine use, and they did include a psychosocial component both in placebo as well as the intervention arm. They saw that across the 2 stages of treatment, there was almost a 14% response for the medication-assisted treatment arm versus 2.5% with placebo. And the overall treatment effect was over 11%. That's basically the difference between response in treatment versus response in placebo. And response consisted of having 3 out of 4 urine drug screens resulting meth negative for any given participant. So it's meaningful. It's worth recognizing, though, what are we talking about here? Just over 1 in 10 people ended up generally abstaining or drastically reducing their use of methamphetamine thanks to this intervention of IM naltrexone and bupropion. Why is it now that many of us are using this form of medication-assisted treatment? Simply put, it's all we have on the medication side. And I'm going to look at our attendees, and I see that Dr. Malcolm Horn has joined us just in time to talk psychosocial. And so I do encourage your support and avid participation here, because this is definitely your wheelhouse, and you can probably do it way better than I can. But to acknowledge evidence-based treatments for methamphetamine use disorder in the psychosocial realm, across the board, all of these have way better efficacy than MAT alone. And in general, if you had to pick between psychosocial versus what we just saw, the IM naltrexone bupropion, you're going to go with psychosocial hands down. Contingency management, which is a form of behavior modification that takes an intervention, and it can be kind of a token offering. For example, giving people gift cards that they can use to purchase coffee, small, relatively benign treats that they only get if they have a certain number of methamphetamine negative urine drug screens. That would be a good example of contingency management. So it's linking that intervention to reinforce a desired behavior, leveraging that incentive. Cognitive behavioral therapy, surprise, it works for almost every type of substance use disorder. The community reinforcement approach works particularly well for helping with methamphetamine use, probably equally efficacious with contingency management. Unlike contingency management, the community reinforcement approach goes beyond simply giving that positive reinforcement. It also involves potentially negative consequences in quick response to a negative measurable outcome, say a methamphetamine positive urine drug screen could result in someone not being able to participate in certain activities that they otherwise enjoy doing. The idea here is you're using a set of positive and negative reinforcement to get the desired outcome, or at least help condition it. And there's a new promise. We're seeing more and more evidence favoring the use of exercise therapy to use it in place of methamphetamine use. And there's evidence of using it in general for psychostimulant use disorders. Malcolm, please jump in here and let us know kind of what your thoughts are and what you think works particularly well in helping people with methamphetamine use disorder.
Absolutely. The CBT is huge. I think particularly once you can get them through kind of like early detox, with methamphetamine, particularly some of our folks who've struggled they've used for a long period of time, we've seen that they really need like an inpatient treatment to get themselves fully out of that environment, get themselves fully detoxed, including like that protracted withdrawal that exists and doesn't exist, where they're really still struggling. And then stepping them down into the outpatient programs with the heavy CBT component, where they really do say, I need to know, how do I deal with my triggers? How do I deal with I see them not necessarily have, I don't want to say cravings. They do have cravings, but it's almost more of feeling not motivated, bored, depressed, and wanting a stimulant to feel better and engaged, versus like some of my patients that struggle with alcohol use disorder, where they're salivating, they're craving alcohol. And I see some of I don't have any necessarily evidence to discriminate the two of them, but I do see the stimulant users really struggling more with, I feel bored, I feel unhappy, and I just need to feel stimulated. I need to feel awake. I need to feel energized. There's actually a new program that we've started at Rimrock called Trust, that is specifically, it's an evidence-based program specifically for stimulant use disorder. It's an outpatient group. It's considered an ASAM level 1 service, where there is that incentivized that they do get the gift cards, they do get the little nuggets of, and I almost look, it sounds bad, but I look at it almost like with a teenager, like, okay, if you don't show up for group, or you don't do your chores, you lose your phone, or you lose, but it's the opposite, where you show up for group, you are peeing clean, you're doing the things, you get a gift card, you get a token, you get something. And those little incremental, you're really building up their tolerance for feeling uncomfortable, their tolerance for feeling bored. You're helping them learn that short-term instant gratification of using is not worth the long-term consequence. Because I see that in this population, they struggle a lot with that, really being able to focus on their long-term benefit of staying clean. It's so hard for them to see it. They don't see a long-term benefit because they're so stuck in that short-term, I need it now, I need to feel good. They really struggle with that. So absolutely, those CBT skills and using those little incentives that we can do in the contingency management, that seems to really work. So I just babbled. Sorry about that.
No, that's wonderful. The
today.
trust. So I think that's spot on. And everything I've read about the trust program, it is robust scaffolding. If you think about it, someone especially freshly detoxed from methamphetamine, they are going to have impaired executive function. In many ways, catecholamines, dopamine, norepinephrine, to a lesser extent, another neurotransmitter, serotonin, they're all at a deficit. And there is significant evidence that people in general recovering from psychostimulant use disorders, they see at least several weeks, if not a few months, of cognitive slowing as they're in recovery. And so, having all that scaffolding is essential. It's in many ways a form of ego surrogacy. You're helping them tolerate the distress and providing a overarching kind of pathway for them to go on and get good reinforcement that's going to be sustainable. Right.
And I mean, I think that those early months sometimes of recovery is so hard for them because of they're not functioning well. They don't feel good. I had one patient tell me, if this is recovery, F it, I don't want it. because they just they weren't happy. They weren't motivated to do anything. They just felt blah. And that's got to be a miserable experience. And so what can we do to help them get through that short-term discomfort and help them trust that it is short-term, it will get better, hang in there, and giving them those wraparound supports is just so important for them.
That's really compelling. To close and wrap up on the objectives, insofar as the mechanism of action of methamphetamine, so it is dopamine, norepinephrine, to a lesser extent, serotonin. Overwhelmingly, it's a surge of dopamine. And that's why, in part, it's so hard to treat, because that reinforcement is so strong. You can see altered mood, disorganized thinking, increased alertness early on. As use proceeds and continues on a chronic basis, people get more and more disorganized to the point that about 40% actually have psychosis. And there is a long-term cognitive impact associated with chronic use. So methamphetamine has been with us, as we saw, since the late 1800s. And the American epidemic is not unique. If we look back to World War II Germany, meth use was rampant and it persisted for some time after World War II. So we may have to go through a protracted course with this epidemic as a nation and find ways that kind of creatively and comprehensively give people what they need to shift patterns of behavior and get away from use. And again, to emphasize, when it comes to treatment, the most effective evidence-based form of treatment is psychosocial. MAT, as we saw, the best we have, offers about an 11% reduction in use, versus when it comes to all the psychosocial interventions, be it contingency management, CBT, or otherwise, we're at least talking about a third reduction, if not more. So that's what we have for the talk. We do have a case, and we are thrilled that nurse practitioner Larissa Hammond is joining us to discuss her case.
Hey, good afternoon, everybody. Okay, so let's see. I think Amber, right? I sent it to you and Dr. Seiss, right? Okay. So I have to be honest. I don't have the actual paperwork that I filled out because it was on the computer. So so I feel really bad about that. But I will tell you that the question was this: this patient of mine was in her 30s, 20-year history of methamphetamine use, and got clean or went to Rimrock, or I guess I don't want to give away any, basically her children were removed from her care, and that was a stimulus for her to get sober. And so so I met this person probably, I don't know, I think I wrote, it was like 4 to 6 months into her sobriety. And she talked about everything you guys are talking about, that where she just had no joy, nothing, there was no joy. And she just, even though she was doing so well and had so many great things, her kids were reunited with
Larissa,
her.
so sorry to interrupt.
Yeah.
We're looking at your submission right now.
Okay.
Amber was able to
good.
find it.
Good. Okay, good. So can you review it for me? What I wrote? Because I know I wrote her GAD score. I wrote PhD.
Yeah. So
degree.
okay.
Yeah.
Well, keep me honest here. I'm looking at what Amber's shared with us, and it looks like it's a common view. So 43-year-old lady
Mhm.
who is separated from her partner, is employed at DoorDash,
Mhm.
and she's in early remission from the methamphetamine use, diagnosed with bipolar disorder, age 21. And
Mhm. Yes.
you do detail the medications. That's wonderful. And also in particular, the prior psychotropic trials.
Mhm.
And what would you, if you had to summarize kind of her chief concern right now in this snapshot in time,
Well,
acknowledging her history, what would you say? What would be kind of the most succinct?
her depression, for
Okay.
sure, without a doubt. And everything that Dr. Horn just said, as far as really, because it was outpatient at this point, right? And just giving her that support and just that this will be okay, that you will get through this. And here's the other rub to this. She has her kids back again, right? And they're young, and so they've missed their mom. And so there's a lot of behavioral issues with the kids. And so there's a lot of parenting, teaching that needs to happen, but everything that she's doing is failing, right? So nothing that she's doing is getting her any further along. And so so the question was, so she had been on Strattera, Wellbutrin, Latuda, and you said that it was there. Are we all seeing what I wrote? Because I don't see it, but in any case, so her thing with me was that she really, really, really wanted to be on Adderall. And because she had used it, before, and she said it made her feel better. But on the same token, there were other things that weren't happening that I needed. So I wanted her to have the support for parenting. So I got her hooked up into the local parenting support groups, specifically with public health nurses that focus on high risk, parenting in these types of situations, and therapy. But therapy just, it wasn't doing a whole lot to target the addiction piece. So yeah, PCIT would be helpful. However, where I'm located right now, she would have to drive to Butte in order to have that happen. So that was kind of it just wasn't something that was going to be able to help her. And so I made her, she started meeting with me weekly. That's what I had her do with me. And just so we could just touch base, just so she would have somebody to touch base with, just to keep her sober. I just didn't know what to do about the medications at that point. How can I best help her? And I didn't want to get her started on something when she was just so early into her sobriety that I don't know if that was the right thought, or if
Larissa,
that was something that
sorry, Larissa, may I ask at this point, for the
Mhm.
purpose of this case, how far out are we from the last use?
Oh, the last use, it would right now, it would probably be about 8 months.
Okay, so
Yeah,
that's
yeah.
significant.
So she's 8, yeah.
It still doesn't
Mhm.
meet full sustained remission, as we haven't hit that
Mhm.
1 year mark,
Yeah.
which is statistically significant because people tend to do a lot better if they can make that year.
Mhm.
And not to dwell too much on that, but you're right in acknowledging, hey, this is still somewhat early. It's an early
Mhm.
remission,
Mhm.
and you're concerned about everything that's co-occurring with
Right.
the methamphetamine use disorder. In particular, given her
Right.
prior
Right.
history. Sorry, go ahead.
Mhm. No, you go ahead, Dr. Seiss.
No, this is, I think it's really compelling to hear your emphasis on what you see in the presentation. So please, Larissa, if you don't mind, I
Yeah.
feel like you were going to emphasize at least one
Well,
more.
she had so many other, 20-year history of meth use. I mean, this person has just great insight into all of this, and has these goals and expectations for her life, but also has these very real issues with trying to parent. She's gained weight since she stopped using, and that's been a huge thing for her. And I mean, it's really hard to be a cheerleader for someone when that is a big deal. And so, setting up, we're working on different programs where I set up things where she chooses something she wants to do that's active and outside and with her kids, and I explain the reasons why we do that. I tell her it clears the fog, so you're able to make better decisions when you get outside. But these are very real issues, and are factors that I know that they're real for her, and this is what she struggles with. Now I certainly am not her therapist at all. And she really does need somebody who can really do that really deep dive in her therapy and helping her to reframe her thoughts surrounding it. And that's what I've been trying to do with her. Like, what is she most afraid of? And what is so good right now about being sober? And what, we have to keep coming back to that. What is happening right now that's so good? And what's good for her is that she is working. She has her kids. She has an apartment. In Bozeman, that's something, and that's
And
huge.
you're focusing on her function.
Yeah.
I think that's very, very pertinent. If I may, I'll try to quickly summarize an identifying statement. Chief concern, 43-year-old woman who is in early remission from methamphetamine use disorder. There was at least at some point concern for bipolar 1. It looks like she was diagnosed with that at age 21 and remains on Latuda as well as lithium. She does have a history of criterion A trauma and is presenting for ongoing medication management, noting that she's dealing with a lot of depressive symptoms. And at one point there was concern for ADHD, to the point that she was previously prescribed stimulants and noted some benefit. Reflecting on what we discussed, I think it was at least 5 sessions ago, treatment of ADHD with co-occurring substance use disorders, there's really compelling evidence that when ADHD and substance use co-occur, they co-occur badly. Each one in some way tends to be more severe than in folks who would just have one of those disorders on their own. And in particular, people benefit a lot from treatment of ADHD, oftentimes with a prescription stimulant dosed toward the upper end of the therapeutic window. Kind of looking at what she has benefited from in the past, in particular Adderall, I'd have to wonder what it would be like to use a prodrug with low abuse potential, Vyvanse, and see if she notes benefit from that. You talk about function, and I think that goes a long ways, in particular in helping somebody sustain abstinence from methamphetamine use, influences in her life that keep her on the pathway to remain abstinent and preserve meaning beyond kind of social fears where she would otherwise be exposed to methamphetamine. Having her kids, her job, these are all really big things. And being housed in Bozeman, that's an accomplishment in itself. So I wonder for her, kind of if we do think about ADHD as a thing and acknowledge there is sufficient concern that we are thinking about treating it, kind of what could we do congruent with everything this patient has going on that's going well for her in those factors of her current function? What could we help identify as a goal that treatment of ADHD may help her achieve? In other words, how would we know if we help her with ADHD treatment, beyond helping her feel better, what does she say it would help her do better?
Well, she's saying, you know what she says, and you're really, I mean, this is why this is so helpful, because it really does, streamline it. But she wants to be a better mom. I mean, that's her goal, and she wants to be able to get up in the morning and be able to do what she needs to do, and for her, I'll tell you, she wants to keep the house clean, all these things that she feels like she has to do, cook the meals, she hasn't been able to do that. But you're right. She really does get distracted, and she gets really down and sad, and then just doesn't want to do anything, but then is yelling at her kids. And is just impatient. And that's pretty remarkable for her to admit that to me. Precisely because she lost her children. They were removed from her care. So I really appreciate her honesty with that. And that she's really trying to work to have a better relationship with them. So yeah, I would agree. I think that's what we could see. We could actually measure that. We could measure, well, how many days a week are you getting up with your kids now, you know, and then how many days a week are you getting up with them after you start this medication?
So just
Yeah.
to interrupt, Larissa, we do have a comment from Melissa.
Oh,
that
oh,
says,
yeah.
And so Melissa, feel free to jump in and just talk. If not, I'll do it. Did I hear you?
Sorry, I can.
Awesome.
Larissa, do you have a release that you can talk with her therapist and work cooperatively for her?
Yeah, so I do, but it's not going well. And it's not the therapist. It's I think it's a connection between the two of them. And she just it's not working for her. And so that's what I keep saying is that, you know, she's had years of it, like in and out of sobriety where she's had therapy over and over and over again. And so she's very insightful, and she doesn't have a lot of tolerance for, I don't even know how to say this, like just talking about stuff, right? I mean, she wants action and she wants steps to get better. And so, yeah, so I really want her specifically with a licensed addictions counselor. And that's kind of where I'm really leaning towards right now. Oh, that's a good comment too. Yeah. No group therapy. Yeah. And no 12-step support, just individual.
Group, I've worked with a lot of patients who particularly, and it's easy to end up with some legal consequences and with the consequences of having your children taken. A lot of patients that I've worked with that have kind of been forced into treatment end up choosing individual therapy over group therapy, and trying to seek that route. And often to their detriment. Group therapy is the standard for addiction treatment for a reason. And individual therapy doesn't tend to have as great a results by itself for that. And if somebody is avoiding 12-step, 12-step groups as well, like that's a red flag. And I think I've also seen working in the family medicine office, like asking about that release of information with the therapist. I have this this concern that I have had patients that come in, and I don't know your patient, but I have had some patients come to their family doctor to kind of circumvent some of the things they're being asked to do in some of their therapy. And so it's been beneficial for their treatment to be able to work cooperatively so that we're not working in opposite directions and kind of pulling treatment.
Yeah. Okay. I think that's a really good point that you make there, Melissa, for sure. I do think that that's what she's doing, because I did kind of throw in that role where I told you I was meeting with her weekly, which is way too much, right? I mean, I'm not doing any med checks or changes at weekly, of course, but just so she'd have someone to check in with. That's the whole point. And they were quick appointments, you know, they're just fast, but just to check in with. But I think you're right. I think, you know, yeah. And Dr. Horn, of course, you know, firing a counselor, you know, that's brilliant. I mean, I've never said that to people. I actually have never said that.
It's so important. One of my colleagues, and so I copy her, she says, finding a counselor is like buying jeans. Sometimes you have to try on a couple pairs till you find the one that fits. And that has to be okay.
Yeah.
I mean, like,
right.
Especially because for therapy, so much of why it works is the relationship you have. And so if it's not a good fit, then you're not gonna have a really good outcome. And so, you know, and so I've even told patients, like, it's okay to fire me. It's okay to be like, Malcolm, you're just not my style. That's okay. And so maybe empowering her to find a counselor that, you know, is dual license or has the LAC to help her with that. And maybe even like peer support, you know, sometimes, and I put that in the chat box too, sometimes peer support is really helpful, because it's like, especially I think with the amphetamines, sometimes they really benefit from, because I can read the books, I can spit the data out, but to talk to someone who's like, yep, been there, done that, bought the t-shirt, sometimes that has a different impact. And so maybe that might be, and that's someone peer support, they could talk to them every day if they wanted to. So she wouldn't need to come to your office. She could do every day touching with her peer support. That would be a good option for her.
Yeah, that is a good option. And I'll tell you, that also jogged my memory because the Department of Family Services has that actually. They have these peer support people. So, and I've worked closely with them for years. So that, yeah. Yeah, I mean, that really, really is. So, yeah.
NA, right? Like you can't beat the price.
Yeah, no, I know that's, yeah, very, very true.
If somebody, so I work a lot with setting people up with the right counselor, and it's not always the right fit, and goodness of fit is really important. But I also encourage people, if it's not a good fit, to go back to their therapist and have that conversation in that, and instead of encouraging, well, just go find somebody else, because it's important for them to be empowered themselves to have that conversation as an adult. And also I tell them, like, chances are your therapist has noticed that too and can refer you to one of their colleagues who they think is a good fit. Like they have resources.
Yeah.
And that way that takes you out of that piece of
Yeah.
being maybe manipulated or.
Yeah, right, right.
But I was also wondering about that piece of the depression. With the being off of meth for 8 months, and if she's wanting the Adderall to give her energy to do chores and things like that, it's like that lack of motivation can be that depression piece as well. And Adderall is not a great fit for treating that if she's looking for it for ADHD kind of stuff, and especially given that, I mean, I would look at that piece too. We might be treating the mania part of her bipolar really well and missing that depression piece. Using meth for a long time, I noticed people in the treatment center I worked in, people hit that. It took a year to feel even remotely normal because they just, their body compensated for that flood of dopamine by trying to shut down their dopamine receptors so they had none for a year.
Larissa, may I ask, how convinced are you about the bipolar diagnosis?
I'm not.
Yeah.
I'm not convinced at all. And I'll tell you, because it was and I will be honest, I don't have any of the old records. They're from all over the place. But it was, I mean, she was using heavily, and when she was diagnosed, and so you know, and then being sober, I mean, she came to me on lithium and Latuda. So already on these medications, and I've adjusted them periodically just because, but, you know, and of course, you know, she had the lithium, and I see Clarissa, I see you wrote that too. And I thought about that with the lithium and reducing that dosage to see if that will help. And so, you know, it's, I mean, I didn't notice anything remarkable going down on it. Does that make sense? I just didn't notice anything significant. Latuda was kind of the same way. And so, but I'll tell you, she's, you know, she doesn't want to go into a situation where then she's in crisis again. And so she's a little bit afraid of that right now as well. So Dr. Seiss, to summarize, I'm really not convinced of it. And yeah, I just don't think her current meds are actually really helping as much as I'd like them to be. And there's other things that I think, you know, need to happen as well. And that's, you know, and you know, and I have, she is coming over to Frontier as well for referral as well. But just because I think she is quite complicated, you know, and I want to make sure that she really does have the best chance at sobriety and getting through this. So.
And we have a comment from Clarissa Juarez,
Yeah.
emphasizing, it looks like we have a few comments. Let me go back here. Emphasizing the concern that bipolar disorder may have been inaccurately diagnosed, just depending on the meth use. And in general, we need to see really at least 1 month of abstinence from meth. Some people would argue at least 3 months before we start looking for evidence of a manic or even hypomanic episode. You know, thinking about medication options and looking in particular on her prior psychiatric med trials, I'm not seeing bupropion.
And I'm sorry that's not on there. It should be.
Oh, she tried it at some point?
Yes,
Okay.
yes, and that should be on there. And I will tell you, she's also, and I have to mention this too. You know, she, and I get this a lot, but they'll say like, she has said that, oh, well, Vyvanse just won't work for me. And you know, those types of things. So and so I'll say, well, that's okay. We're not quite there yet anyway. So we'll talk about it as it gets closer.
Yeah.
You know, so, and I asked, why do you think it didn't work? And I think because she's still in that phase of using. And of course, she didn't get the hit like she did with Adderall. And I don't know if it was IR or extended release. I don't even know what I wrote. I'm so sorry.
This is very comprehensive insofar as the history.
Okay.
So thinking about options for treatment of ADHD, especially given the risk profile of something like Adderall, I can't see a compelling reason to go with that, even if she were to insist that's the only thing that offered her benefit in the past. If for no other reason, there's no safeguard against abuse. Whereas with a prodrug like Vyvanse, she essentially can't abuse it other than, you know, an outright overdose.
Right.
And thinking about kind of putting this together with MAT, of course, acknowledging that it's not super effective, but it is something. Bupropion could be an option. And if we're at all concerned that she may have something on the bipolar spectrum, it's worth noting that of all antidepressants, bupropion has a relatively low risk of flipping into mania, in part because it's not serotonergic. And I just included a link to an article I found helpful. So kind of thinking through everything it's taking, it may be a sweet spot to, I'm sorry, I sent that direct. Let me put that out to everyone. It may be a sweet spot to try to get her on MAT for methamphetamine use disorder. Also leveraging therapies, acknowledging that, yeah, definitely engagement in 12-step is going to be huge. And trying to do therapy alone is off and avoidant of the evidence so far as what really helps with psychosocial interventions.
Well, I'm going to do the peer support for sure, because I think I can get buy-in on that one, because she has a good caseworker at the department. So, I think I can get really good buy-in. So, okay. Oh, I'm actually figured out my computer so I can actually see what I wrote. Yay. So now that we're at the end of it. Yeah.
This is a really compelling case.
Yeah, I'm pretty proud of her. She's really working really hard. She was enrolled at one point, or enrolled, I don't know what the word is, in a Ideal Options here in Bozeman. I don't know if anyone's familiar with this organization, but the medication assisted treatment there, and it just didn't work for her. And I really didn't there wasn't really any really good reason why it didn't. It just didn't. She said, I just didn't fit in. So,
and that was for Vivitrol?
Yes, it was. And so, but I really don't know. And that was out after I didn't arrange for that. That was part of the, when she left her treatment facility. And so that was part of her ongoing care. She just, I mean, I really don't even remember how she found me, but I think she was just referred. I think that they called just looking for someone to see her and help manage her medications on the outside. So, yeah. Okay, well, I think I have a good plan here.
Would it be all right if we ask you for an update in a few
Yeah,
weeks?
no, that would be great. That would
Excellent.
be really good. Yeah, that would be good.
Well, thank you everyone for a great discussion. Really, really compelling case. I feel like it highlighted a lot of the concerns in treating methamphetamine use disorder.
Yeah, thank you guys for all the options. I really do appreciate it. I really do appreciate it. So,
And just a plug for cases, I usually send out a reminder about a week prior. And as you can see, it's not super scary to be the one that's presenting. And I will keep your forms for you. So
yeah, I'm really sorry. Really
no
sorry.
problem, no problem.
Yeah.
But we all do learn better when there's a case to apply what we're learning about. So if you have one of those difficult cases or something that you just have questions about, just feel free to send us some forms. We're happy to review.
And it doesn't necessarily have to be specific to the topic of the day. Anything dealing with substance use disorders, co-occurring disorders, we really appreciate it. It's so kind of fertile insofar as a space for us to really develop these ideas and learn from each other.
Yeah. And I will put one more plug in since we have exactly 4 minutes left. We do want to have a very robust evaluation of this program. And so when you all registered, if you remember way back then, we asked you a series of questions. And so we are going to send out a survey with a link to a very similar type survey to see what kinds of things changed for the people that have attended. So if nothing's changed, that's fine. You can tell us that too. But we really want to evaluate the effectiveness not only of this echo session, but as we develop and continue to offer 3D echo across our entire region. And for those of you that don't belong to Montana, Alaska, Wyoming, and Hawaii, you're always welcome, and your input is helpful as well. So.
Great. Well, we hope you join us in 2 weeks to discuss substance-induced psychosis.
Very good.
All right.
Okay.
Take care, everyone.
Bye,
Bye-bye.
guys. Thank you.
Bye.